Hello, everyone. I'm Dr. Eddie Markle, the EMS Medical Director from Illinois Masonic, and welcome to Trauma 3, Part 1. I know what a lot of you are thinking. Last time we saw this guy in that room, it was an hour and a half long. No worries. I can assure you today it will not be an hour and a half. My goal is to keep this under 30 minutes. Because if you think getting through that hour and a half Con Ed was difficult, imagine trying to make it. A couple of words on the format today. I'm going to kick it off with part 1, and this is obviously going to be the YouTube format that you're watching right now. I'm going to go through head injury, dental and facial injury, and traumatic arrest. After that, you're going to head over to Dr. Tataris in part 2. After you complete that, you'll take the test, and you'll get your 2 hours of Con Ed. A few words on how I think you should take this Con Ed. Everything we're going to talk about today is based on the General Trauma Management Protocol. So I think it'd be great if you guys could review that before going any further. Also, there are PDFs available of the protocols that I'm going to be talking about today. I'm not going to be reading verbatim through this. It's not going to be like a book on tape. So I think it would be very useful if you were to go ahead and read through those before going any further. Just hit pause. I will still be here. And without further delay, let's get to head injury. Let's get the most important points concerning the treatment of head injury out of the way, and we'll reemphasize these throughout this section of the module. Our goals are to make sure we have adequate oxygenation, to maintain blood pressure, and to limit the development of increased intracranial pressure. The primary goal in the treatment of traumatic brain injury in the pre-hospital environment is to prevent secondary brain injury. If we provide people with optimal treatment, we can give them the best chance they have at a good functional outcome. Let's start by looking at some brain anatomy and physiology to better understand what optimal treatment for traumatic brain injury is. The brain is not known for its resilience. It's susceptible to physical injury as well as low oxygen states. Luckily, nature has done a great job with providing us some protective mechanisms. I'm going to talk about a few of these. I'm going to talk about the skull, as well as the layers around our brain called the meninges. And then I'll talk a bit about cerebral autoregulation. First off, let's talk about the skull and the meninges. The skull. The skull does a great job at protecting our brain. It's made of solid, thick bone. It completely surrounds the brain, protecting it from any physical insults from the outside world. When we take a look inside, we see the brain safely nestled inside the cranial vault. We'll take a look at the meningeal layers and see that the brain is actually floating around in a fluid called cerebrospinal fluid, further protecting it from any physical insults. Here is an image of the layers that surround the brain called the meninges. On top we see the skull. Just underneath that, there is the dura mater. No, that's not a misspelling, it's actually mater. Underneath the dura mater is the arachnoid mater, and then finally the pia mater. You can see there's a space between the arachnoid and the pia, and this space is filled with cerebrospinal fluid. This fluid offers a protective cushioning to the brain to further protect it from any kind of blunt force trauma it may experience in the world. We get to this section on brain injury and the types of intracranial bleeds. I'll provide some clinical correlation between these layers surrounding the brain and the types of bleeds that people could experience with head injuries. Although the skull does a really great job at protecting the brain, there is one shortcoming. This solid, thick bone protecting the brain cannot expand. This means if there is any swelling on the inside, the pressure on the inside is going to go up, leading to an increase in intracranial pressure. Stay tuned for why this is important and what we can do about it. Now let's talk briefly about cerebral autoregulation, another protective mechanism that I mentioned. It refers to the brain's ability to maintain stable blood flow despite changes in blood pressure. Under normal circumstances, the brain can maintain its blood flow over a wide range of blood pressures. However, if the brain sustains a traumatic injury, this protective mechanism becomes disrupted. This is where we have the ability to make a difference. By maintaining the blood pressure, we're going to prevent secondary brain injury, giving the person the best chance they have at a successful outcome. Before we jump into the pathophysiology of traumatic brain injury, let's establish a guideline of how we're going to rate head injury severity. I'm not going to talk about how we treat a particular type of traumatic brain injury, but I am going to talk about how we treat mild, moderate, and severe head injuries. You can see by this guideline on the screen that mild is going to be defined as a GCS of 13 to 15, moderate will be a GCS of 9 to 12, and severe will be a GCS of 3 to 8. The AVPU rating is also listed on the screen. I'm back. I want to talk about 3 pathologic brain changes that occur with traumatic brain injury. First, I want to talk about increases in intracranial pressure and resulting potential herniation syndromes that can occur. Second, I'd like to talk about the loss of cerebral autoregulation. And third, I'm going to talk about changes that occur with penetrating head injuries. So how does intracranial pressure increase after a traumatic brain injury? Let's use our model to help demonstrate this. We can see here the brain is sitting comfortably inside the intracranial vault, no excessive pressure on it. But it sustains a traumatic brain injury. There's a significant amount of bleeding. And now we take a look and we see the brain is being compressed to one side. As I mentioned before, this intracranial volume is fixed. There's only so much space. So as you're adding a bleed in there, what's going to happen is that the pressure is going to start increasing on the inside. Let's look at a few more examples to help demonstrate this important point. This example demonstrates conditions inside the brain when the intracranial pressure is normal. The contents of the intracranial vault are represented by the rectangle in the center of your screen with 2 spigots on the end. As you can see, the contents of the intracranial vault under normal conditions are composed of the brain, the cerebral spinal fluid, the arterial volume, and the venous volume. Now let's look at what happens when we add a brain bleed to the mix. You'll note there's a new section shaded purple inside the rectangle that I've labeled brain bleed. In this first example, there's an injury, but there's compensation. What happens is the venous volume and the cerebral spinal fluid volume are decreased inside the intracranial cavity. Because of this, the intracranial pressure stays normal. The ability to compensate has its limitations. As the mass gets bigger, the venous and the cerebral spinal fluid volume only can go down so much. After they could go down no further, the intracranial pressure will start to elevate. So what's the big deal with increasing intracranial pressure? Let me tell you, it is a downward spiral that, if not corrected, will ultimately result in the person dying. What happens is, at first, there's compression of the brain tissue. This leads to decreased perfusion and hypoxia at the tissue level. The cells could die, resulting in edema, further worsening intracranial pressure. As the pressure continues to increase, we have compression of the cerebral vessels, resulting in more decreased perfusion, further worsening the situation. Eventually what will happen is there'll be so much swelling the brain will start to herniate. And once herniation starts to occur, death is not far behind unless the situation is corrected. Let's take a look at some examples about brain herniation to better illustrate this. To help visualize what herniation means, here's a cross-section of the brain with 6 types of herniation that can occur. Cerebral herniation occurs when the intracranial pressure increases, displacing the brain within the cranial vault. This displacement results in the brain being either compressed up against or through structures inside the the cranial vault. Taking a closer look at a particular example of herniation, we see a hematoma expanding, causing increased intracranial pressure. This is displacing the uncus, a part of the brain, through the connective tissue floor. As the compression associated with brain herniation continues, eventually the midbrain and the brainstem will be affected. These parts of the brain are responsible for us being awake, our respirations, and our heart function. As the compression continues at these regions, eventually this will result in death. Here are the signs of brain herniation that you all need to be aware of. You might not see every sign in a particular patient. The one sign that you will see in every patient is decreasing mental status. This occurs due to compression of the reticular activating system in the midbrain. An abnormal respiratory pattern can be present. One classic example is the irregular breathing pattern called Cheyne-Stokes respirations. This pattern is characterized by a progressively deep and sometimes faster respiratory rate that gradually slows down to a pause and then repeats, speeding up again with the deeper, faster rate and then slows down again. In Region 11, we do a great job at assessing people's pupils. Try saying that really fast a couple of times in a row. If we encounter somebody who has decreased mental status and an unequal pupil, we need to be concerned that this patient could be experiencing herniation. This syndrome is caused by compression of the third cranial nerve that controls the ability of the eye to constrict. Everyone should be familiar with the next two signs of brain herniation, as they are part of our GCS scale. The first is decorticate posturing, which is flexed posturing. Next is decerebrate posturing, which is extended posturing. Note that there is a worse predicted outcome if a patient is exhibiting decerebrate posturing. Finally, there is Cushing's response to increased intracranial pressure. This response features an elevated blood pressure, a lowered heart rate, and irregular respirations. A lot of you are probably thinking, gosh, we're spending a lot of time talking about increased intracranial pressure. What can we really do about it? At the end of the day, these people do need urgent treatment at a trauma center. But we do have some tools to help the patients before they arrive. One of those tools is to optimize the amount of carbon dioxide in the patient's bloodstream. Remember, we can track this by using the end-tidal CO2. When the end-tidal CO2 is elevated, the cerebral vasculature is dilated, which leads to an increase in the intracranial pressure. When the end-tidal CO2 is decreased, the vasculature constricts, and this lowers the intracranial pressure. There is a sweet spot for the optimal end-tidal CO2 for patients exhibiting signs of herniation. That sweet spot is an end-tidal CO2 between 30 and 35. With this end-tidal CO2, there's enough constriction of the cerebral vessels to lower the intracranial pressure, while at the same time maintaining oxygen delivery to the brain tissue. As we'll note a bit further in this module, you will need an advanced airway to get this end-tidal CO2. For an end-tidal CO2 below 30, what happens is the cerebral blood vessel constricts so much there's impaired oxygen delivery to the brain tissue, which is deleterious. Another thing we can do to improve intracranial pressure is to elevate the head of the bed to 30 degrees for patients with severe head injury. By doing this, we improve venous outflow and lower the intracranial pressure. All right, let's move on from intracranial pressure to cerebral autoregulation. Everybody hopefully recalls cerebral autoregulation is the body's ability to maintain blood flow to the brain under a wide range of blood pressures. You can see from this graph that the body is able to maintain a constant cerebral blood flow from a fairly low to a fairly high blood pressure. When a person experiences a traumatic brain injury, cerebral autoregulation becomes impaired. Let's take a look at the dotted line on this graph that represents cerebral blood flow after a traumatic brain injury. You'll note that cerebral blood flow is no longer constant under those range of pressures, but now varies as the blood pressure changes. As the blood pressure goes down, so does cerebral blood flow. This can result in hypoperfusion and ischemia to brain tissue that is already very susceptible to damage. For patients with a traumatic brain injury, it is essential that we maintain perfusion by maintaining their blood pressure. We do this by providing IV fluids to target blood pressures. We'll talk about those specific targets in the intervention section. The final thing I want to talk about in this section on pathophysiology is the open skull injury. My grandmother once said you should never touch the brain, and truer words were never stated. When there is an open skull injury, the brain, which is normally completely protected and sterile inside its case, is now susceptible to the outside world. What we don't want to do is put any direct pressure on there or get any further contamination that has already happened. So we don't directly press the area where there is a suspected open skull injury. And if we do suspect it, we go ahead and cover the area with a moist, sterile dressing. For this assessment section, I'm just going to hit the high points. First point I'd like to make is that there is an association with cervical spine injuries and head injury. About 5 to 8% of people with a traumatic brain injury will also have an associated cervical spine injury. So remember to have a high index of suspicion for a spine injury when you see a head injury. The next point I'd like to make is the need for frequent and close monitoring and reassessment if necessary. A brain bleed that starts off relatively small like this could easily change to large bleed like this. We already talked about the signs of herniation, increased intracranial pressure, and you're going to see those signs. What's important is to keep a very close eye on the patient and watch for those changes and intervene when necessary. Our goals for interventions are to ensure adequate oxygenation, ensure adequate brain perfusion, and to prevent any secondary brain injury. We've got all the background information that we need, so let's go ahead and talk about the specific treatments and intervention for traumatic brain injuries. Airway. We need to ensure adequate oxygenation and prevent any hypoxic episodes. We're going to administer oxygen as needed to maintain a saturation of greater than 94%. We're going to ensure that the patient has a patent airway. If necessary, we'll do a jaw thrust. We could also use our airway adjuncts, such as an oral or nasal airway. Remember the caveat that if the patient has significant facial injury, we should not be using a nasal airway to prevent placing that nasal airway inside the patient's brain. Oral tracheal intubation or a supraglottic airway can be used if bag valve mask ventilation is ineffective at maintaining oxygenation, or if the airway is unable to be maintained through other means. Keep in mind though, if you are going to use an advanced airway, hypoxia must be avoided. This means to adequately pre-oxygenate the patient and quickly securing the airway. Remember, a supraglottic airway can be placed much faster than an endotracheal tube. By choosing a supraglottic airway, you're going to minimize the possibility of a hypoxic episode while securing the airway. For patients with a severe head injury showing signs of herniation, it is appropriate to do controlled hyperventilation to lower the end-tidal CO2 to 30 to 35. As you recall from the section on increased intracranial pressure, this will cause vasoconstriction and lower the intracranial pressure, hopefully temporizing the situation until you arrive at a trauma center. Remember, no overly aggressive hyperventilation. We do not want to go below an end-tidal CO2 of 30. And just as a reminder for those of you who just took the cardiac module, the normal target end-tidal CO2 is 35 to 45. This point about correctly targeting the end-tidal CO2 is so important that I have a little skit to help everybody remember.
My ventilation rate is too fast. The cerebral vasculature is constricting too much, causing impaired oxygen delivery to brain cells. some of which will die, I'm not going to have the best possible outcome.
My ventilation rate is too slow. The cerebral vasculature is dilating too much, causing an increase in intracranial pressure and worsening of herniation. I am not going to have the best possible outcome.
My ventilation rate is just right. I'm being given the best chance for a good outcome.
As I have mentioned several times, it is essential to maintain blood flow to the brain for patients who have experienced a traumatic brain injury. Here are the blood pressure parameters for moderate to severe head injury. For adults, our target systolic blood pressure is 110 to 120. For pediatrics, the target for less than 1 month is greater than 60. For 1 to 12 months, the target systolic blood pressure is greater than 70. And for 1 to 10 years, the target systolic blood pressure is greater than 70 plus 2 times the age in years. Unfortunately, you'll have to do a little math on those cases. For patients 11 years old and greater, use the adult target systolic blood pressure. For patients whose systolic blood pressure is below target, provide a fluid bolus in order to meet the target blood pressure. Remember, do not delay transport to initiate IV access. This should occur during transport to the trauma center. Do not overlook other causes of altered mental status that could be present in somebody with a head injury. Make sure to check the blood glucose and treat if appropriate. And also, if there's suspicion of a narcotic overdose, provide the patient with Narcan. There can be multiple causes of altered mental status in the same patient. For example, somebody could have both a head injury and a low blood glucose, or a head injury and a narcotic habit. Just because you find an alternate cause of altered mental status besides head injury, if they have signs of a head injury, they should be treated as a trauma if their GCS is 13 or less. A few more points on disability. You'll be doing your spinal assessment and management, and as I mentioned, there is an association of head injury with cervical spine injury, so make sure you have a high index of suspicion. Perform your neurologic exam and closely monitor the patient for deterioration. The first sign of deterioration is going to be a change in mental status, confusion, agitation, drowsiness, vomiting, complaint of a worsening headache. And as I mentioned previously, if the patient has a severe head injury, elevate the head of the bed up to 30 degrees. A quick review on the pertinent Region 11 trauma field triage criteria for people with a head injury. Step 1 criteria would be the GCS of 13 or lower. Step 2, penetrating head injury or an open or depressed skull fracture should be taken to the closest appropriate trauma center. There are 2 patient populations identified in the Step 4 criteria that deserve special mention. Older adults undergo anatomic changes in their brain that make them more vulnerable to intracranial hemorrhages after seemingly minor head trauma. In the spirit of the Step 4 criteria, an older adult with a head injury does not meet absolute criteria to go to a trauma center, but it does cause you to call for online medical control to discuss the case to determine whether or not the patient should be diverted to the closest appropriate trauma center. Patients who are on anticoagulants or have a bleeding disorder are at high risk for deterioration after sustaining a head injury. This patient population is at much higher risk for sustaining an intracranial bleed after head trauma. Also, their bleeds can be much larger and much more severe than somebody who has normal clotting ability. All right, let's wrap up this section for head injury. What do we learn when it comes to patients with head injuries? No hypoxia, no hypotension. When it comes to the development of increasing intracranial pressure, we're going to do what we can to prevent it from getting any higher. This means proper positioning of the patient, and if they have an advanced airway, making sure we have our end-tidal CO2 tightly controlled between 30 and 35. All right, we're finished with this section. Let's move on to facial and dental injury. On to facial and dental trauma. In this section, we'll be expanding on the care we already discussed in the general trauma management protocol. Our goals are going to be to make sure we maintain a patent airway, to preserve vision, preserve teeth, preserve noses and ears, and to control bleeding. Let's discuss the pertinent anatomical considerations for this section. The first consideration is the amount of vasculature in the face and the scalp. Penetrating wounds will bleed a lot, so it is essential to obtain early bleeding control. As I mentioned in the previous section, uncontrolled bleeding in the face and the scalp can result in hemorrhagic shock. The bleeding issue will be further exacerbated if the patient takes an anticoagulant medication or has a bleeding disorder. We've all heard the phrase, time is brain and time is myocardium. Well, here's another one. Time is tooth. An avulsed tooth that is properly handled and stored and brought with the patient promptly to the hospital has a good chance of survival if reimplanted within 60 minutes of avulsion. It is our job in EMS to make sure that we are handling and storing the tooth properly. When handling the tooth, be sure to only handle at the crown. I demonstrate what the crown is by the blue arrow. This is the part of the tooth that you see when you open your mouth. This is contrasted by the root, which is shown using a red arrow. You should not handle the tooth by the root. There is a fragile structure on the root called the periodontal ligament. Handling the tooth by the root can destroy this ligament and worsen the chance the tooth can survive. Regarding avulsed ears and noses, similar to teeth, if these tissues are properly handled when avulsed in the pre-hospital environment, we are going to give the patient a best chance that these avulsed tissues can be reimplanted successfully. Our primary concern for facial and dental injuries is to make sure the patient is able to maintain a patent airway. Normally, the bony structures of our face and jaw provide good structural stability to make sure the airway stays open. When the jaw or the structures of the face are broken, this integrity is compromised, meaning it could be harder to keep an open airway. Let's dig a little bit deeper on this issue and explore some of the ways in which the airway can be compromised through trauma. After an injury to the face, physical obstruction can occur through distortion of the anatomy. The bones can become malaligned, or a hematoma can occur. Both of these situations can cause narrowing and possible obstruction of the airway. In this example, we see a bilateral mandibular fracture causing a hematoma underneath the chin. Remember, a supraglottic airway can be placed much faster than an endotracheal tube. By choosing a supraglottic airway, you're going to minimize the possibility of a hypoxic episode while securing the airway. Injuries to the face can cause bleeding into the airway, sometimes significant. In this example, we see an open mandible fracture resulting in significant bleeding into the mouth. If the patient is also on an anticoagulant, we could expect the bleeding to be more severe. The combination of the physical injury, bleeding into the airway, and potentially a co-occurring head injury can result in a situation where the patient has the impaired ability to handle secretions. It is essential that we closely monitor the patency of the patient's airway and be prepared to position and provide treatments to the patient to maintain that patency. On to our assessment. Remember, the assessment is going to be based on the general trauma management protocol. I'm going to point out a couple of highlights specific to facial and dental injury. First, the airway. As I already mentioned, patency is key. Assess the airway for patency, and if it is patent, keep monitoring to make sure it stays that way. Remember that if there is loose dentition, these could be aspirated. We mentioned bleeding and the potential for severe bleeding. Remember to evaluate for anticoagulant usage or bleeding disorders. For the cervical spine, there is also an association of cervical spine injury and facial injury, so have a high index of suspicion for the need for spinal motion restriction. For injuries that involve the eye, be sure to perform a gross visual assessment, such as having the patient count fingers. Next, I'd like to talk about the collection phase. If the patient has any missing teeth or missing tissue such as nose or ear, make sure to collect this tissue and handle and store appropriately. And remember about missing teeth. A missing tooth could be in the patient's airway and could pose a risk to airway obstruction. Be sure to closely monitor. For this section on treatments and interventions, I am only going to be discussing the unique aspects of this particular protocol. The overriding theme for this section of the module is to maintain a patent airway in patients with facial injuries. Maintaining the airway is your highest priority. This means that a patient might not be able to comply with our usual spinal motion restrictions. If spinal motion restriction is resulting in an impaired airway, the patient should be allowed to position themselves in the position that maintains their airway. This typically means having the patient sit up. Also, have suction available for these patients because they might have impaired ability to clear their secretions. If an avulsed tooth is readily available on scene, we want to make sure we collect the tooth and transport appropriately. If the location of the tooth is not obvious, we do not want to waste time on scene trying to locate the tooth. Avoid touching the root of the tooth and make sure not to wipe off the tooth. Pick up at the crowned end. Please note the blue arrow pointing to the crown on the tooth to the right. If the tooth is dirty, it can be rinsed off under cold water for 10 seconds. And the transport media is either milk or saline, milk being most preferred if available. For eye trauma, our primary objective is to prevent further injury. This can be accomplished by covering the eye with an eye shield if it is available. For globe avulsion, there is an example to the right. It is essentially the eyeball being displaced outside of its socket. Do not place any pressure on the eye to try to reduce it back into the socket. Rather, cover it with moist saline dressings to protect it from further injury. For unstable mandible fractures, aka the lower jaw, expect that the patient will not be able to spit or swallow effectively. Make sure you have suction available. And remember, as I already mentioned, the preferred position to transport these people is sitting up with an emesis basin and suction. For nosebleeds, squeeze the patient's nose as such, or have the patient do so, and continue this for 10 to 15 minutes. For nose or ear avulsions, our goal is to try to preserve this tissue. Try to recover the tissue if it does not significantly increase scene time. Transport the tissue wrapped in dry gauze in a plastic bag placed on ice. Severe ears and nose lacerations can be addressed by covering with a protective, moist, sterile dressing. All right, let's wrap up this section. It's all about preserving. We're going to preserve the airway. We're going to preserve teeth. We're going to preserve vision. We're going to preserve noses and ears. And finally, we're going to make sure we're controlling bleeding. All right, let's go on to traumatic arrest and we'll finish out my section. Let's start off this section by discussing the goals of patients in traumatic arrest. The first is rapid evaluation and treatment of patients in traumatic arrest to provide the best possible outcome. We'll be using our general trauma management protocol for this. Next, assessment for signs of life to determine if resuscitation is indeed indicated. And finally, transport of traumatic arrest patients meeting criteria for resuscitation to the closest appropriate Level 1 trauma center. This means for patients aged 15 or less, they'll be going to a pediatric level 1 trauma center. For ages 16 above, they'll go to the closest level 1 trauma center. Before we go any further, I have to clarify something very important. The treatment of a patient in traumatic arrest is not the same as the treatment of a patient in cardiac arrest. Let me repeat that point in a less subtle way. Traumatic arrest does not equal cardiac arrest. So we all know about the treatment of cardiac arrest. Unless you've been living under a rock, you've received multiple updates on incident command for cardiac arrest and the right way to do a resuscitation for cardiac arrest. It essentially is the stay and play model, meaning that resuscitation occurs on scene. We don't move the patient unless there is a scene safety issue. And for cardiac arrest, EMS has the right tools for the disease process. You have the ability to defibrillate. You could perform quality compressions. You have the appropriate medications to treat out-of-hospital cardiac arrest. One of the main reasons why incident command for cardiac arrest is successful is because the blood is still contained within the vascular system, which is exactly where it should be. Now let's contrast what we just discussed about cardiac arrest with what is going on in traumatic arrest. The most common cause of traumatic arrest is going to be acute blood loss, meaning the blood is no longer in the vasculature. Other causes of traumatic arrest could be a direct injury to the cardiovascular system. The aorta might be disrupted and no longer capable of transporting blood. Or there can be an obstruction to cardiac output, such as a tension pneumothorax. There are several other causes, but I just want to demonstrate that traumatic arrest, pathophysiologically speaking, is completely different from what is happening in cardiac arrest. For traumatic arrest, if the patient is going to have a chance at survival, it is essential to minimize the time it takes to get them to the closest appropriate level 1 trauma center. If resuscitation of the patient is appropriate, resuscitation will start on scene but continue while in transport to the closest appropriate level 1 trauma center. For traumatic arrest, trauma surgeons have the right tools for the disease process. It's the job of EMS to stabilize the patient while transporting them. Our assessment begins with performing a thorough patient assessment and evaluating for any signs of life. This includes respirations, pulse, or spontaneous movement. If there are any of these signs of life, resuscitation must start immediately and preparation started to transport the patient to the closest appropriate level 1 trauma center. In accordance with our policy determination of death withholding of resuscitative measures, the following conditions qualify for withholding resuscitation when no signs of life are present. These conditions are decapitation, transection of the torso, and incineration, which means 90% of total body surface area burns with full thickness burns. If your assessment reveals the patient has a traumatic injury and no signs of life, the next step is to apply the cardiac monitor and determine the cardiac rhythm. If the patient is in PEA, then resuscitation must begin and transport should begin to the closest appropriate level 1 trauma center. If the patient is in asystole and multiple leads, it is appropriate to withhold resuscitation and to contact online medical control. The following conditions are excluded from withholding resuscitation. To put it another way, if a person has one of these conditions, you must start resuscitation immediately. This includes drowning or strangulation, lightning strike or electrocution, situations involving hypothermia, patients with visible pregnancy, or the mechanism of injury does not correlate with the clinical condition suggesting a non-traumatic cardiac arrest. A good example of the last condition is a person who is found unresponsive and pulseless in a low-speed motor vehicle collision where there is no damage to the automobile. The person in this case likely had a cardiac arrest and lost control of their car, then sustaining the collision. In these circumstances, the patient should be treated in accordance with incident command for cardiac arrest. If there is any clarification that is needed in these circumstances, please feel free to call online medical control. Let's discuss the treatment and interventions appropriate for traumatic arrest. Resuscitation of traumatic arrest includes external hemorrhage control, airway management, chest compressions, pelvic stabilization if indicated, and pleural decompression if there is traumatic arrest with thoracic trauma. Note that epinephrine is not recommended for patients in traumatic arrest. A few closing points for traumatic arrest. Remember that resuscitative efforts should not prolong scene time. One of the goals of the treatment of all trauma patients is rapid transport to the closest appropriate level 1 trauma center. And just to remind everyone again, if you're 16 and up, you go to a level 1 trauma center. If you're 15 and below, you go to a pediatric level 1 trauma center. And finally, patient care is the responsibility of EMS. For scenes involving law enforcement, a full patient assessment is still required to determine the need for resuscitation. Well, that's the end of part 1 of Trauma 3 module. Hopefully you all survived my portion of it. I look a touch disheveled, so hopefully you fared better than me. Now move on and take part 2 of Trauma 3 with Dr. Katie Tataris. Thanks everyone for your attention. Have a great rest of your day.